Hey guys, it's Medicosis Perfectionist one more time, continuing our playlist called Pulmonology. In previous videos, we start talking about lung infections and lung abscess. Today we'll talk about tuberculosis, also known as Phthisis pulmonalis. If you know Phthisis pulmonalis, you're very old school. You're probably older than 70 years of age. With that being said, now let's get started. A very brief history lesson about the guy who invented the stethoscope. He's a French physician and musician called René Laennec. His mother died of tuberculosis. Oops, which inspired him to actually help patients with tuberculosis. He used his skill of carving flutes made of wood to invent the stethoscope, and he called this method of auscultation mediate auscultation, as opposed to immediate auscultation, which was used in the past. And this old method involved putting your ear on top of the patient's chest. Imagine if the patient is a female. Very embarrassing. After inventing the stethoscope, do you think people cheered and everybody celebrated? No, people with theories, also known as professors, actually mocked him. One of them said, "He that hath ears to hear, let him use his ears and not a stethoscope." Oh, just shut up. When people make fun of you, you're probably on the right track. If your morbidly obese friends with BMI over 35 are making fun of your diet plan, it's probably a good plan. If your broke friends are mocking your financial plan, you have a shot at being rich. Not only did this medical professor mock him, L.A. Conner, the founder of the American Heart Association, also made fun of them. He was not convinced. He used to carry his handkerchief to place it on the patient's chest wall for immediate auscultation. He was not convinced yet that there is a better solution called mediate auscultation. Laennec was a hard-working stud. He invented the stethoscope. He coined the term whispering picturoloquy. You know, when you tell the patient to say 1, 2, 3, 1, 2, 3 in a whispering sound, and then you put the stethoscope and you hear it like this, 1, 2, 3, 1, 2, 3. This is consolidation, probably a pneumonia. He also termed that name melanoma, and he was the first guy to discover that melanoma can metastasize to the lung. He published his book titled, let me try my French, De l'auscultation médiate traité au diagnostic des maladies du poumon et du cœur. My French is awful. Translation: On the immediate auscultation, or treatise of diagnosis of lung and heart diseases. Diseases are maladies. Du poumon is the lungs, du cœur is the heart. That's why we have a condition called cor pulmonale. It's a problem in your heart, le cœur, caused by a problem in your lungs, du poumon. So in English, it's called heart. In Latin, it's called cor. In French, it's called le cœur. In Spanish, it's called corazon. These people were sitting in the same room while inventing this kind of stuff. For those of you who are into ancient literature, de l'auscultation médiate au traité, why or? Why of the immediate auscultation or treatise of diagnosis of whatever? Because this is the title and this is the subtitle, but they didn't do this back in the days. They said this or an explanation or the subtitle. I think I should change the name of my channel into Medicosis Perfectionalis, where medicine makes perfect sense. Laennec used his stethoscope to diagnose tuberculosis, also known as Phthisis pulmonalis. Pulmonalis, we get it, it's the lung. What does phthisis mean? It means wasting or invasion or destruction. You know, there is a disease in hematology called myelophthisis, which we have talked about before. Myelo is the marrow. Phthisis is wasting of the bone marrow due to invasion by cancer, by infection, etc. Phthisis pulmonalis is wasting of your lung because of the stupid tuberculosis. Why didn't they just name it tuberculosis right away? Because you're sitting in the 21st century and theorizing about the ancient world. This was very old. And when we say tuberculosis, osis means condition. Tubercle is a granuloma. we have to discover the bacilli, then discover that the bacilli cause a type 4 or delayed type hypersensitivity reaction. Then this will get the epithelioid histiocytes, also known as macrophages. They will form this granuloma and surrounded by Langerhans multinucleated giant cells and fibrous tissue. This was not discovered back in those good old days, which were not so good. This happened later. But they said this lung has been wasted. Let's call it phthisis pulmonalis. Makes sense. He helped many patients with tuberculosis, but later he died of tuberculosis. Oh my goodness, I've made so many videos about leukemia. This makes me so sad. I'm gonna die of leukemia. He died at age 45. Like most of you watching this are in your mid-20s, so this is half of Lennox's entire life. What have you done with your life? Except sitting in your mother's basement on your butt, bragging on Twitter about your new iPhone 11 Max Pro. You are such a pathetic weasel, and I am not any better. His legacy remained prominent in many medical terms such as Lennox cirrhosis, Lennox pearls, sputum in asthma patients, also known as Kirschmann spirals, Lennox Hammond murmur, which is not actually a murmur, it's a pneumomediastinum. Primary TB versus secondary TB definition. This is the first infection. Secondary TB is reactivation of a previous TB infection or reinfection. Primary TB pathogenesis. Early on you have no immunity. This Mycobacterium tuberculosis comes in and goes here. Subpleural. Lower part of upper lobe or upper part of lower lobe. Usually in the right lung. Early you have no immunity against the Mycobacterium tuberculosis because this is your first exposure. Therefore, you cannot localize the lesion. Therefore, it will spread, leading to the Gons complex, which is lung tuberculosis, plus TB lymphangiitis, plus TB lymphadenitis. Later, you will develop immunity against tuberculosis, and then you will be able to localize the bacilli, and you will develop hypersensitivity leading to formation of central caseous necrosis. And this is what causes caseating granuloma. Secondary TB, if the patient is immunocompetent, he has memory cells, active immunity, the second reaction is going to be faster and stronger. The patient will have strong immunity, able to localize the lesion in the apex, and have a strong hypersensitivity leading to caseation. But if the patient is immunocompromised, let's say HIV, no immunity, no localization, spread of the infection into miliary TB. Organs affected in primary TB only for lung, skin, tonsils, or intestine. Tonsils, why? Drinking milk contaminated with Mycobacterium bovis, this is called bovine tuberculosis. Or intestine due to the same problem, please pasteurize the milk. Because some of you who live in like first world countries, your daddy is super rich, you have never struggled with money, you did not struggle with cholera, so you get bored. You go on an online blog and read how to live a, quote, all-natural, zero artificial life in homeostasis with the earth, whatever that means. And then the article made by this online blogger living in his mother's basement described pasteurization as an evil process done by greedy corporations who abuse their workers. You start to believe him, and then you said, I'm not gonna pasteurize milk anymore, I'm gonna drink raw milk straight from the cow. So you drive your electric car, which is ironically made by a big corporation, to the farm. Drink milk straight from the cow without pasteurization. Welcome to bovine tuberculosis land. And in your first world country, the chances of you meeting a doctor who has ever seen bovine tuberculosis is zero. When people get affluent, they get bored. And when they get bored, they do crazy butt stuff. Sorry guys, I'm just joking with you. Secondary TB is different. It goes to the apex, forming a cavity. Primary has no cavity, and it will invade the tributaries of pulmonary veins, translation the lungs. It can cause TB bronchopneumonia, and it can spread leading to miliary TB if your immunity is weak. Why did we call it miliary TB? Because it looks like a millet seed. and this can lead to cervical or mediastinal lymphadenopathy. This is painful because this is an infection, not hilar. I said cervical or mediastinal. What's the difference between hilar and mediastinal? This is a big discussion. Hilar lymph nodes drain into the mediastinal lymph nodes. Next, heart, leading to TB pericarditis, which is a constrictive pericarditis, dystrophic calcification leading to pericardial knock. Instead of lub-dub, you have lub-knock, and this will lead to Kussmaul sign, which is jugular venous distension on inspiration. Vertebra can lead to Pott's disease, which is a cold abscess involving the body and the disc. Bone marrow will lead to leukoerythroblastosis, which has immature white blood cells and immature RBCs. It's like being crazy and stupid. Immature white blood cells are called blasts. Immature RBCs have a nucleus. TB can go to the brain into meningitis with headache, nuchal rigidity, and neurological symptoms, and maybe fever. Kidney leading to nephritis and hematuria. Adrenal, secondary Addison's disease with hypocortisolism, increased ACTH, hyperpigmentation due to melanotropic stimulating hormone due to pro-opiomelanocortins. Can go to the liver leading to granulomatous hepatitis, to the intestine, to the peritoneum leading to TB peritonitis, epididymis leading to epididymitis and male infertility, fallopian tube leading to salpingitis and female infertility. Primary TB, the patient is usually immunocompetent. Secondary could be immunocompetent or immunocompromised. Location, primary TB is subpleural. Primary is subpleural, secondary involves the apex and there is cavitation. How about caseation? In primary TB, early there is no caseation because there is no immunity or hypersensitivity. Later there is caseation because there is hypersensitivity. Secondary, yes, there is caseation. How about cavitation? Primary does not have it, secondary does. Gons complex, yes, what the flip is it? Tuberculosis in the lung plus TB lymphangitis plus TB lymphadenitis. No, in secondary. Hilar lymph node involvement, yes, usually no. Why? Because you have memory cells and you will be able to contain the stupid bacilli and it's not going to be able to spread. Cold abscess, no, but in secondary, yes, because you have weak immunity, you cannot produce strong inflammation with redness, hotness, swelling, pain, loss of function. When it's not hot, it's called cold. Primary tuberculosis, infected person, cough or expectoration, inhalation of the bacilli by a normal person, now the normal person is infected. It goes to the lung, play odds, right or left, most commonly the right, because the right mainstem bronchus is more vertical. Early, there is no immunity. This is your first exposure to the freaking bacilli. There is no localization. It spreads to the lymph vessels, lymphangitis, and lymph node lymphadenitis. But later, you'll be able to localize and form a caseating granuloma. What the flip is a granuloma? It's CD4 positive T helper cells, delayed type or type 4 hypersensitivity reaction. The macrophages, also known as epithelioid histiocytes, will come, and then they will surround this stupid bacilla because they cannot kill it, but they can contain it. So they will contain it, and then multi-nucleated Langerhans giant cell will form, and then some fibrous tissue around this, and this is a granuloma. If you have strong hypersensitivity due to a strong immunity, you will be able to form a central caseating necrosis, and this granuloma is called a caseating granuloma. What the flip is TB bronchopneumonia? TB bronchopneumonia can happen with primary or secondary. So you have TB, let's say it's primary and it's subpleural. It starts to drain. We're starting to drain it and cough it out. While it drains, it came back. So we're trying to drain it and it came back. Trying to drain it and came back. Came back to the lower lobe, maybe. And now it's gonna lead to pneumonia or consolidation. This is called TB bronchopneumonia. Really bad, and it could be fatal. Risk factors of TB including weak immunity and exposure to a person with TB. So children, elderly, people living in poverty or crowded areas, prisons or jails, which is like, they are not the same, please talk to your lawyer. Cigarettes, malnutrition, contact with patient with active TB. If the patient has dormant TB, he cannot infect you. Measles, please vaccinate your kids. Vitamin deficiency, drugs, chemotherapy or TNF-alpha inhibitors because they weaken your immunity, can lead to reactivation of tuberculosis. What's the fate of primary TB? Usually self-limiting, leaves a small trace called a nodule, which is fibrocalcific and can lead to scarring. Tuberculous bacilli can remain dormant in that location for decades or even for life. What is it waiting for? It's waiting for your immunity to drop, and then it's gonna reactivate, leading to secondary tuberculosis. If you do X-ray or CT scan, you'll see calcification, this old fibrous or fibrocalcific nodule, and this is called Ranke's complex. And as we have discussed before in my video called Solitary Pulmonary Nodules, calcification on X-ray is usually benign. Primary TB can lead to complications with fever and pleural effusion. It can lead to TB bronchopneumonia. It can lead to development of immunity, memory T cells, and hypersensitivity. So the next exposure is going to be faster and stronger, and we will be able to contain the stupid bacilli, forming a cavity in the upper lobe of the lung. Or a rare complication is called progressive pulmonary fibrosis, when you cannot find the bacteria, and this will lead to something called non-reactive TB. This caseation may erode into the vessel or lymph node, leading to disseminated tuberculosis or miliary tuberculosis, even in primary TB, which is very rare. Why is Mycobacterium tuberculosis acid fast? It's thanks to mycolic acid in the cell wall of the stupid thing. Is the secret weapon, aka the virulence factor in Mycobacterium tuberculosis? It's the cord factor. It contributes to the pathogenicity. It gives the ability to colonize the human host. It induces granulomatous reaction. If you have weak immunity, such as HIV patient, you have increased risk of progression from dormant into active TB. It's called TB reactivation or secondary TB. You have increased risk of TB reactivation and death. Clinically speaking, primary TB is usually asymptomatic, may have cough, rarely hemoptysis, could be fever. Signs: hyperthermia, maybe tachycardia. Radiologically, chest X-ray or CT scan, you'll see that Ranke's complex, and it's subpleural because this is primary TB. If this is secondary, it's gonna be the apex, baby. Complications of primary TB could be pleurisy, pleural effusion, TB bronchopneumonia, or pneumothorax. Secondary TB, aka reactivation TB, can affect any freaking organ caused by reactivation or reinfection due to weakness of the immunity or due to reinfection, HIV/AIDS, lymphoma, chemotherapy, immunosuppressants, especially TNF-alpha inhibitors. Elderly patients, secondary TB might arise from a nidus of calcification of the primary TB. Why does secondary TB go to the apex of the lung? 3 reasons. Number 1, Mycobacterium tuberculosis is a strict aerobe. Please don't say there is more ventilation in the apex, because this is not true. There is more ventilation in the base. But there is a higher VQ ratio in the apex. Please watch my video on VQ mismatch to understand more. Let's do it in a very simplistic way. Between fluid, which is blood, and oxygen, which is air, which one has a better chance of escaping gravity and going upwards? The answer is air. Air, right? Apex. Reason number 2, there is less blood in the apex because gravity pulls the blood downwards. There is more blood in the base of the lung. If there is less blood in the apex, there is less white blood cells in the apex to fight the stupid infection. Number 3, there are a lot of lymph vessels near the apex, and tuberculous bacilli or Mycobacterium tuberculosis loves invading lymphatics. What causes cavitation in secondary tuberculosis? The release of cytokines from memory T cells. That's why you only see cavitation in secondary tuberculosis because there is memory, but not in primary tuberculosis because there is no memory yet. Symptoms of secondary TB: cough, usually productive of blood-stained sputum, or it could be even frank hemoptysis, fever, weight loss, drenching night sweats, anorexia, malaise, chest pain, weakness, symptoms specific to the organ. A typical exam question will describe a patient with productive cough, frank hemoptysis, weight loss, drenching night sweats, and night fever. Signs: pleural friction rub, hyperthermia, tachycardia, etc. Complications of tuberculosis: it's an inflammation, therefore you can get anemia of inflammation, aka anemia of chronic disease. TB forms a cavity, at least secondary TB. Aspergillus fumigatus can invade this cavity and come on top of the cavity, forming an aspergilloma, also known as a fungus ball. Amyloidosis, imagine my shock, like it's a chronic inflammation. And bronchiectasis. If you have watched my previous video on bronchiectasis, I've told you that bronchiectasis is caused by recurrent airway infection and inflammation. Screening for TB, not for everybody. You screen for the latent TB, the dormant TB. Who needs screening? If you have HIV, IV drug abuse, homeless, prisons, jails, nursing homes, poor communities, migrants, healthcare workers, or those who are in close proximity to TB patients. There are only 3 screening tests available. TB skin test, also known as tuberculin skin test, also known as purified protein derivative test, also known as PPD test, also known as Mantoux test in French, also known as intradermal TB skin test. Any of these names can come on your exam. Technique: you inject the patient with PPD, purified protein derivative, which is derived from tuberculosis. You wait for 72 hours. Why 72 hours? Because this is a delayed type hypersensitivity reaction, or type 4. You look for the reaction, and this is an induration. And then you measure the induration. Do not measure the erythema. So if this is the induration, like this, and it's usually surrounded by erythema, which one should you measure? You should only measure the induration. This part, not the erythema. Get your head out of your sphincter. Pros of tuberculin test: easy and minimally invasive. Cons: does not distinguish between active TB, inactive TB, or previous BCG vaccination. If high pretest probability exists, negative tuberculin test does not exclude TB. Example: let's say a patient came from Egypt, which has a lot of TB, by the way, and he has fever, frank hemoptysis, pleuritic chest pain. He just came out of prison. Most of the inmates had tuberculosis. You did PPD test for this patient and it came back negative. Question: does this rule out TB? No! The second test is interferon gamma release assay. Third test is chest x-ray. I'll tell you a personal story because I have nothing to hide. I was born in Egypt. When I came to the United States, they screened me for TB first. So, here is how it went. They did the PPD test. In Egypt, they actually vaccinated with BCG vaccine. They do not do this in the United States. But the employee didn't know that. So she said, "Son, your TB test came back positive. You'll have to go into a treatment regimen for 9 months of isoniazid." I said, "What?" By the way, there is a vaccine in Egypt called BCG vaccine. I think the reaction came back positive because of the vaccine. Let's do the interferon gamma release assay and a chest x-ray. She said, "Okay, sounds like a plan. But if they came back positive, you're getting the treatment." I said, "Fine." We did the interferon gamma release assay and the chest x-ray. They were as clean as the blank slate of Jean Locke. She said, "Okay, son, you're cleared. Hey!" How to diagnose tuberculosis? Sputum analysis. Usually you ask the patient to cough and get a sample, or you do a bronchoalveolar lavage, which is even better. Acid-fast stain. Why? Because it detects mycolic acid in the cell wall. This does not stain well with gram stain. Acid-fast stain has many different names or techniques. Ziehl-Neelsen stain, Kinyoun method, fluorescent Auramine-Rhodamine stain, or Fite stain. Any of these can come on your exam. Cultures for Mycobacterium tuberculosis. What are the pros? Standard diagnostic test. What are the cons? Take up to 10 weeks. Oh, forget it. 3. Liquid media based radiometric assay. Pros: only 2 weeks. Slightly better. Principle: it detects metabolism of the TB bacilli. This is similar to PET scan for cancer. Because PET scan for cancer, it detects cancer metabolism. Cancer cells are very active and they divide rapidly. They replicate faster than you change underwears. If they divide rapidly, they use lots of glucose and they will shine on PET scan. Number 4 is PCR. Very accurate, rarely used. Other options: nucleic acid probes, nucleic acid sequencing, interferon gamma release assay. Better than tuberculin skin test when patient was previously vaccinated with BCG vaccine, like my story from Egypt, or when the patient is non-compliant. If there is high pretest probability, again, negative interferon gamma release assay does not exclude TB. Also, the PPD test, if it came back positive, it does not exclude TB if you have a high pretest probability. There is another test called quantiferone TB, gold standard test, and there is radiology, chest X-ray. If it's primary TB, subpleural fibrocalcific nodule. Secondary, cavity in the apex, and TB is one of the causes of a solitary pulmonary nodule. If it's miliary TB, diffuse reticulonodular infiltrate, and you can find TB in other organs. Prognosis of tuberculosis. It depends. If you have strong immunity and a local disease, good prognosis. Weak immunity plus disseminated miliary tuberculosis, poor prognosis. Treatment of tuberculosis. Please, if you suspect tuberculosis, treat for tuberculosis. Do not wait for stupid, bizarre, fancy tests. How to treat latent or dormant TB for patients who are at risk of reactivation. Example, HIV cases, etc. Aim to eradicate the tuberculosis and prevent reactivation. Method: INH for 9 months. Remember the government employee who was screening me against tuberculosis and my PPD test came back positive even though I didn't have tuberculosis? What did she tell me? You need to get INH for 9 months. Or INH rifampicin weekly for 3 months or rifampin daily for 4 months. Treatment of active TB. RIPE. R is for rifampin, I is for isoniazid, P is for pyrazinamide, E is for ethambutol. Rifampin, isoniazid, pyrazinamide, ethambutol. Instead of ethambutol, you have an option of giving streptomycin, but do not use this. It's an archaic drug that's only used today for the plague. In the first 2 months, give 4 drugs. Give rifampin, isoniazid, pyrazinamide, and ethambutol. In the next 4 months, give only 2 drugs, INH and rifampin. So the total is 6-month treatment regimen. Side effects of TB medication. Very common questions during exam. Isoniazid, vitamin B6 deficiency leading to peripheral neuropathy, seizure, sideroblastic anemia. So whenever you give INH, please give vitamin B6 at the same time. If I ever hear that you give isoniazid to a patient without giving vitamin B6 simultaneously, I'll kick your butt, metaphorically speaking. HAGMA, high anion gap metabolic acidosis, drug-induced lupus, and you'll find positive antihistone antibodies. It's a P450 inhibitor. Translation, it's gonna inhibit the liver enzymes. Translation, it's gonna decrease metabolism and increase toxicity of other drugs. And it's toxic to the liver. Check the LFTs, liver function test. Next, rifampin. Red orange, that's why I had a red color, discoloration of all bodily fluid. So your saliva are orange, your urine is red. If I'm writing an exam question, I'll describe while a couple were having sex, they noticed that the vaginal lubrication fluids of the female was red to orange color. Good luck if any student can answer this question. I need to get my head out of my sphincter. P450 inducer. Translation, it induces the liver enzyme. Translation, it increases metabolism of other drugs. So, if you are giving a patient, let's say, warfarin, and this warfarin is anticoagulant, and then the patient is taking rifampin at the same time, you will need to increase the dose of warfarin because this current dose is no longer effective because you are increasing metabolism of warfarin. Otherwise, your patient is gonna clot. So, up the dose, baby. Rifampin is also hepatotoxic. Pyrazinamide, hyperuricemia, don't ever forget that. Liver toxicity, please do not use it in pregnancy. Ethambutol, visual abnormalities, red-green color blindness, and it decreases the visual acuity. To screen for decreased visual acuity, use Snellen's chart. To screen for red-green color blindness, use the Ishihara color blindness test chart. Please use your search engine to look this up because it's freaking amazing. Ethambutol can lead to visual field defect. Use gross confrontation test or perimetry. Ethambutol is the only one that's not hepatotoxic. How about streptomycin? It's an aminoglycoside, and this mnemonic is from Dr. John Baroon. Nephrotoxicity, this is the N. O is ototoxicity, which is irreversible. Auditory plus vestibular. You damage your hearing and your balance abilities. Also, this ototoxicity is additive. Translation, if you use another ototoxic drug, such as loop diuretics, furosemide, plus streptomycin in the same patient, you have very, very high risk of ototoxicity. aminoglycoside. Do not use it in pregnancy, it's teratogenic. My favorite part of the lecture, clinical pros. The most common cause of vitamin B6 deficiency is isoniazid. In tuberculosis, TNF-alpha maintains the granuloma. Silicosis increases your risk of tuberculosis. Silicosis increases your risk of lung cancer. Asteroid bodies as well as Schumann bodies can be seen in sarcoidosis and tuberculosis. Please do not confuse Schumann bodies seen in sarcoidosis with Kirschmann spirals seen in asthma. Intestinal tuberculosis, aka bovine tuberculosis, can mimic Whipple disease. Both of them have bacilli inside the macrophage. In case of tuberculosis, it's the tubercle bacilli or Mycobacterium tuberculosis, but in Whipple disease, it's the Triphorema whippeli. Who named these bugs? Also, both of them are PAS positive. So, how can you differentiate between intestinal tuberculosis and Whipple's disease? Only the tuberculosis is acid-fast. Whipple is not. Interferon gamma and TNF-alpha and nitric oxide are responsible for inflammation and bacterial containment. If you have high pretest probability, negative tuberculin test does not exclude TB. If you have high pretest probability, negative interferon gamma release assay does not exclude TB. If an HIV patient who is being treated with protease inhibitor at the moment, please do not give him rifampin. Instead, give rifabutin. Risk factor for TB activation include recent infection, fibrotic lesions, tobacco smoking, malnutrition, comorbidities such as HIV, silicosis, big time, diabetes because of the weak immunity, chronic kidney disease, ILS, diabetes again, like what the F. Thank you so much for watching. Please subscribe and join the tribe. Hit the bell and smash like. Follow me on Facebook. I have 100 cases there. You can get my notes, my premium videos, my slides for this video and every other videos in Dropbox folders. Just go to patreon.com/medicosis. Thank you so much for watching. Until next time, be safe, stay happy, and study hard. This is Medicosis Perfectionalis. Medicine makes perfect sense.